All right, so tonight we're going to go over monitoring anticoagulation. And this video could be useful to those that are in complex as you're learning about pulmonary embolism. But it also can be useful to those that are in the adult classes. We're learning about deep vein thrombosis as well. So monitoring anticoagulation is going to be something we're going to do in both classes. So let's first start out by talking about what labs that we're going to monitor. Want to think about for the three common medications we're going to give for anticoagulation, which is enoxaparin, or also known as Lovenox, heparin, or Coumadin, also known as warfarin. What is the laboratory test that I'm going to do to monitor these, and why am I even monitoring them in the first place? What's the therapeutic value? So let's kind of back up a little bit here. Why am I monitoring in the first place? So either my patient has a blood clot in their leg, in their lungs. That's the two scenarios we're really looking at specifically here. But because of that, I can't, these medications do not break down the clot. What they do is they stop you from forming new clots. So there's maybe a process in your body where your body is forming clots more frequently. And especially once you have one clot, there's a higher chance of you getting another blood clot. So what we want to do with these medications, our goal is to stop you from forming clots so easily. So normally, like if I cut myself right now, my body's going to come to the rescue, and in a few seconds, it's going to clot and stop that bleeding all by itself. And so I have there's a short period of time that it's going to take for my clotting process to happen. Now, that's great for me. I don't have any blood clots in my body that I know of. But for a patient that has a blood clot, we want to prolong the amount of time it's going to take before they're going to form a blood clot. We don't want to get crazy with it. We don't want to make it too long. We want them to still be clotting, but we don't want them to clot so easily. So as a nurse, who's that's taking care of a patient with a DVT or pulmonary embolism, I'm going to manage their anticoagulation and watch the levels, in their blood to make sure that they're getting enough so that they're not forming blood clots so easily, but also not getting too much where they have a high risk for bleeding. And so we'll kind of talk about that. Um, so if I have a patient that's on enoxaparin, also known as Lovenox, the monitoring is actually very simple. For this patient, I don't actually have to monitor anything to make sure it's enough or not too much. All I need to do is monitor their platelets. So enoxaparin is also known as low molecular weight heparin, so it's a type of heparin. So there's a syndrome known as heparin-induced thrombocytopenia, and patients that are on enoxaparin, even though the risk is lower, it is still possible that they're going to have that interaction or that issue. So I'm going to monitor their platelets to make sure their platelets are not going low. And so, of course, for platelets, we want that number to be between 150 and 400,000. If it starts dropping real low and it's dropping a lot every day, I'm going to need to contact the physician and let them know that this patient might be having a reaction to the medication. For heparin, there's two ways that heparin can be given. I can give heparin shots, and most of you, this is probably what you're familiar with. You go into the hospital and a patient is getting those shots. Well, that's just like given the enoxaparin or the Lovenox. It's going to take a little while for it to be absorbed. I don't need to monitor anything continuously, except for on a daily basis. I'm probably going to check their platelet count again to make sure that they're not going into the heparin-induced thrombocytopenia. The more specific case that we're going to talk about here, and we're going to do some practice problems with this, is that for a patient who has a deep vein thrombosis or a patient that has a pulmonary embolism, they could be on a continuous IV heparin drip. And with this one, again, we're going to need to monitor the platelets because it's heparin. So we're going to need to monitor that their platelets aren't decreasing. But there's a lab that is specific to monitor if this medication is effective. So you know how I'm always annoying and I'm always asking, ask yourself, well, how do you know this medication is effective? This is the answer for heparin. I know it's effective if my APTT, it has to be that lab. We cannot monitor heparin through an INR. We have to monitor the APTT. That's the one that is specific to heparin. And that's a more deep in-depth thing that you need to understand. But just know for heparin, my lab that I watch is the APTT. That is the lab that I'm going to look at. The other ones, it's not that they don't necessarily matter. Like I said, I'm going to watch the platelets, but it's not that the INR doesn't matter. But I can't look at my INR and know how my heparin's doing. I can only look at my APTT and know how my heparin's doing. But anyway, the per your book, the normal is 46 to 70. But and that's kind of for testing purposes. Those are the numbers that we'd be focusing on. But just be aware that in a hospital or somewhere you might work, if those numbers are different, you're just going to follow your protocol. But effectively, if you look in your book and look up a normal APTT, it's going to be less than this, and you're going to say, wait, that's not the normal value. I don't want to know what the normal is. I don't want a normal clotting value in a patient that has a blood clot. I don't want them forming clots. So this number is actually greater than normal because I want them to the point where they are going to take more seconds to form a blood clot. Because I don't want, like, again, I don't want them to get crazy. I don't want them to be taking minutes to form a blood clot because, like multiple minutes, because then they could bleed to death. But I want this number to be not normal so that they're not going to be such a high risk of forming more blood clots because they already have one. For Coumadin, this medication is given PO. And so, or by mouth. And so this is usually like in the hospital, they're going to be on heparin. And then when they go home, they're going to go home on Coumadin. And for Coumadin, remember how with heparin, the PTT is the lab that we're watching. Well, for Coumadin, I'm watching the INR, the international normalized ratio. And the normal INR, well, I'm going to back it up. The therapeutic INR is 2 to 3. So again, I don't want a normal INR. I think a normal INR is like less than 1, but I want it to be more than normal because I don't want this patient clotting very easily. I want it to take more seconds for them to start clotting because they have a blood clot and I don't want them to have more. So in other words, this is how I know these medications are effective, is that they are in this range. This is telling me if my Coumadin's between 2 and 3, or if my heparin's between 46 and 70, this is telling me that my heparin is at a safe level or my Coumadin's at a safe level. And so I want to keep it in that range to make sure that they're getting what they need. And to kind of put it into context, if this number gets too high, if I get above 70 seconds or above 3 seconds here for these values, then I'm a high risk of bleeding. If it's going to take a lot of seconds, like I mentioned, for me to form a blood clot, as much as I don't want them to form a blood clot, again, I need them to have some ability to form some sort of clot because otherwise I would bleed to death. I need to have some clotting ability. I just don't want them to have too much. And then again, on the opposite end of the spectrum, if my HPTT is less than 46 or less than my INR is less than 2, these numbers are low, then I'm going to be at risk for clotting. Again, I want to keep in this range. Like this is my happy place, my happy space, where if they're in this range, this is telling me that they are going to hopefully be at a level where they would be at low risk for getting a blood clot, but also not a high risk for incredibly high risk for bleeding. If the number was higher, they would be at a much higher risk. So these medications, even though they have a therapeutic range, people commonly can get too much of these medications. So when they do, we have to have a reversal agent. So for both enoxaparin and heparin, we use what's called protamine sulfate, and this reverses this. So if a patient starts bleeding to death or they have too much of the medication, I can give protamine sulfate, and it's going to decrease that level of heparin in their body, and also can help to stop with that bleeding process that's going on, so they can go back to their normal clotting process. And if I have a patient who's on Coumadin, we give them vitamin K or FFP, and that's the reversal agent for Coumadin. So just real quick, I was going to mention the differences between heparin and low molecular weight heparin, because some people find this confusing. There's 3 main differences. One is the monitoring. Like I mentioned, low molecular weight heparin doesn't have any monitoring aside from watching the platelets. So that's really friendly for people that maybe have to go home on this for a short period of time. A lot of patients aren't going to keep up with a lot of monitoring, and so it's really good to have a medication that's more low maintenance, so it requires less work for the patient to do. That means they're more likely to comply with that therapy. It also has less side effects. So heparin can have some side effects of, some bone breakdown if it's given long term, and can have a lot of what do you call it? There's a lot of other like long-term side effects if you have to be on it for more than a short period of time. And so as a whole, low molecular weight heparin has less side effects. Oh, that's what I was going to bring up. I was trying to think. I was like, I know it's going to come to me. The heparin The regular heparin has a higher chance of getting the heparin-induced thrombocytopenia or the HIT syndrome, whereas the low molecular weight heparin has a lot lower chance of that. So as a whole, less side effects with this low molecular weight heparin. And then I need to consider the half-life. So as a whole, why do we use heparin and low molecular weight heparin? We actually, we like both of these to use them in the hospital over Coumadin. Like if a patient comes in, they have atrial fibrillation, they've been on Coumadin for a long period of time, we usually switch them to heparin because heparin and low molecular weight heparin have a short half-life. In other words, they're in your system and out of your system pretty quickly. And that's really favorable because what do people in the hospital need? Well, we got to poke them a lot. Sometimes they need surgery, they need other interventions. So I want them to have a medication that I can easily, it can easily get out of their system without having to, hopefully, I shouldn't have to reverse it, but it gives them enough time. So like, for example, if I have a patient on a heparin drip, I can turn that drip off and they can go to a surgery in a few hours and they can be okay and not be high risk for bleeding. But if I have a patient on Coumadin, it can take days before that's out of their system. Because remember, it's oral, it's metabolized differently. So as a whole, both of these have a shorter half-life, but heparin IV is going to have a shorter half-life than the low molecular weight heparin. Because remember, this is given sub-Q, so it's given in your tissue, given over time. So usually low molecular weight heparin will go out of your system in about 12 hours, but where regular heparin, it can be out of, I want to say it was like 90 minutes it can get out of your system. So there's also that difference in that heparin, that's a great medicine. Like if I need to start it but stop it abruptly because I need that out of my system, that's something that's very convenient about that and helps to increase safety if they need like an emergent procedure, then they can, what do you call it? They would probably prefer to use the IV heparin. All right, so let's do some scenarios real quick and let me get out of this. I'm gonna go to scenario 1. All right, let me bring this up. So let's look at some scenarios when a patient's on a heparin drip and kind of see how I would mediate these. So let me get my little marker here. So let's read this first scenario. So client is currently receiving 18 units, and that's something to note. Heparin comes in units. Just kind of like insulin, but it's a different, it's a different measure in the sense that, you're not using insulin syringes with these. So anyway, 18 units of heparin an hour. Their PTT or their APTT, however you want to look at it, comes back at 89. What action needs to be taken and what should be adjusted to their hourly dose? So I am currently on, let's see if I can find my little mouse thing here. There you go. I am currently on 18. So that's my starting dose that I'm on right now. And then I check my labs and it's at 89. So what I'm going to need to do is I'm going to need to come over here to my table. So again, this is not necessarily going to match what the normals in your book, but this is just like a sample. Let's see if I can find this. Okay, there we go. I was just trying to find my marker there. But anyway, this is just a sample like chart that we're using here. So anyway, I'm going to find, let's see if I can find my mouse again. Keeps disappearing from me. Okay, so I'm looking down here and trying to find my number. So my normal is 89, or not my normal, but my lab comes back at 89. So that fits into this one. So here, all I have to do is check my labs and then I look at my orders and it's going to tell me what to do. So the question's asking me, what should their adjusted hourly dose of medication be and what is your biggest concern? So if my PTT is 89, is it too high or too low? It's too high. So remember, we want it like, here it says that their range is 50 to 75, but like I said, 46 to 70 is usually what we're shooting for on the exam. But this is too high, which means that I'm going to be at risk for bleeding. So yes, they're going to be at risk for bleeding because that number's too high. They have it's taking too many seconds for them to form a blood clot. So what this is telling me to do, I need to hold this medication for 30 minutes and decrease the dose by 2 units. So my new dose over here is going to be 16 units per kilogram per hour. So that's just to kind of give you an example of what that looks like. So let's do another one. So currently the patient's receiving 14 units. Their PTT comes back at 42. So let's look to see what I'm going to do over here. So 42 fits into my orders over here. I'm just, all I did was look for my number. Oh, sorry, bad drawler. So when my PTT is 40 to 49, um, again, we think, is this too high or too low? What's the problem? Well, 42 is less than my therapeutic range. So I'm not getting enough, which means I'm going to be at risk for clotting. So yes, so what this says is that if I'm at this, I need to give a bolus. In other words, I need to give like an extra bolus dose. And then I'm also going to increase my dose. Let me see where I'm here. Okay, there I am. So I'm going to increase by 2. So I'm going to increase my dose to 16 units per hour. And then I'm also going to give plus the 3,000 unit bolus because they do not have enough. And I want them to be at a range where they have enough anticoagulation, but not too much. So hopefully it's starting to make sense. Let's do another one. So this one says that the client is receiving 22. Just don't mind me. I suck at this and this is hard to see. And that their PTT comes back at 59. And what action do we need to take? So 59 falls into, let's see where I'm here. Okay, let's see. Falls into this. So what this says here is that this is my target range. Because again, if you think about it, even if we're going with our range, 46 to 70, 59 fits in that same range. So what does this tell me? If I'm in my therapeutic range, what is my action? Nothing. Not applicable. I don't need to do anything because my range is normal. I don't need to adjust my hourly rate because I'm exactly where I want to be. And I'm not concerned because the patient has enough anticoagulant to support them, but not too much. So this is exactly where I want to be. So this is just kind of a quick tutorial to look at some of these anticoagulants. Hopefully it was more helpful than confusing to you. Some of these can be a little bit tricky, but just remember our overall goal for these medications is to get enough to support the patient where they're not going to be forming clots easily, but not too much where they're going to be at higher risk for bleeding. So hope this was helpful and I'll catch you next time.